Assalamu alaikum wa rahmatullah. Our topic today is testicular tumor. Testicular neoplasm occur in roughly 6 per 100,000 males in the age from 15 to 34 years old age group. When these neoplasms peak in incidence, they are the most common tumor in men. Neoplasm of the testes are heterogeneous, that means different, and include germ cell tumor and sex-cord stromal tumors. In postpubertal males, 95% of testicular tumor arise from germ cells and almost all are malignant. All testicular tumor arise from germ cells, that means almost all of it are malignant. The age of the patient, as well as characteristic elevation in the level of serum tumor marker in different subtype of germ cell tumor, can be very helpful in predicting the type of the tumor. Non-Hodgkin lymphoma, the most common testicular tumor in men older than 60 years. Testicular neoplasm are the most common cause of painless testicular enlargement, not like the testicular torsion and orchitis and the benign lesions. Testicular neoplasm is characterized by painless testicular enlargement, okay? That is important difference between the benign lesions and malignant lesion. They occur with increased frequency in association with undescended testes, as we said in the previous session, and with testicular dysgenesis. Risk factors. Testicular tumor are more common in whites than in black. Cryptorchidism is a risk factor. Intersex syndromes, including androgen insensitivity syndrome and gonadal dysgenesis. Family history. For example, if there is a brother of males with germ cell tumor, these have 8 to 10-fold increased risk of malignant neoplasm. Previous history. The development of cancer in one testis also is associated with markedly increased risk of neoplasia in the contralateral testis. Intratubular germ cell neoplasm, the precasal lesion of testicular germ cell tumor, is thought to be intratubular germ cell neoplasm. This may be regarded as a variety of carcinoma in situ, that's mean occurring within the testicular tubules, not invade the other structures in the scrotum, just inside the testicular tubules, even not invade the stroma. These cells are recognizable histologically, being larger and more polymorphic. There is different types of cells than normal spermatogonia. Clinical feature, we said there is painless testicular mass. Seminoma often remain confined to the testis for long period before metastasis. Non-seminomatous germ cell neoplasm metastasize earlier by lymphatic as well as hematogenous route. Classification of the testicular neoplasm. There is germ cell tumor, sex-cord stromal tumor, and mixed tumor. Germ cell tumor has subtypes. Seminomatous tumors include seminoma and spermatocytic seminoma, and non-seminomatous tumors include embryonal carcinoma and yolk sac tumor and choriocarcinoma teratoma. Sex-cord stromal tumor include Leydig cell tumor and Sertoli cell tumor, and that means this is the stroma of the testis, or mixed tumor. Seminomas, this 50% of testicular germ cell neoplasm is seminoma. Identical to tumors called dysgerminoma, identical to the dysgerminoma in the ovary, okay? And germinomas which occur in the CNS and other extragonadal sites. Peak age is from 40 to 50. 10% of patients have elevated HCG. Spread predominantly via the lymphatic system and is very radiosensitive and is good prognosis. This tumor, this seminoma, have characteristically uniform, slightly lobulated in the cut surface. This gross picture, observe it is very uniform and slightly lobulated in the cut surface. This is a microscopic picture of seminoma. Observe the there is large cells. This is a pale color. Large cells with distinct cell border. The cell border is very clear, with pale nucleoli, and prominent nucleoli. And this dark basophilic is a lymphatic infiltrate. Spermatocytic tumor patients generally are beyond 50 years of age, microscopic. There is small, medium, and large polygonal cells, and there is no lymphatic infiltrate in spermatocytic tumor. Embryonal carcinoma, this occurs in from 20 years old. It is ill-defined. There is no well cell border like in seminoma. There is ill-defined, invasive, massive, containing foci of hemorrhage and necrosis. The tumor cells are large and have basophilic cytoplasm. Basophilic, that means like purple. Indistinct cell border, large nuclei, and prominent nucleoli. Pure embryonal carcinoma account for only 3% of all testicular germ cell tumor. Yolk sac tumor, the most common primary testicular neoplasm in children younger than 3 years. 90% of patients have elevated alpha-fetoprotein, and this is a good tumor marker to follow. The tumor composed of poorly differentiated endothelium-like cuboidal or columnar cells, characteristically presence of structure resembling primitive glomeruli, the so-called Schiller-Doval bodies. These often have eosinophilic. Eosinophilic mean like red. Observe there is red color in this picture. Hyaline globules containing alpha-1 antitrypsin and alpha-fetoprotein. 90% of patients have elevated alpha-fetoprotein. This choriocarcinoma, it occurs in age from 20 to 30. 100% of patients have elevated HCG. Is a tumor in which the pluripotential neoplastic germ cells differentiate into cells resembling a placental trophoblast. From that, the name. It is called choriocarcinoma because it resembling placental trophoblast. The primary tumor often are small and non-palpable, even in patients with extensive metastatic disease. Teratoma is a tumor in which the neoplastic germ cell differentiate along multiple somatic cell lineage. All age from infancy to adulthood can occur in them teratoma. In adult, pure teratoma are rare, constituting 2 to 3% of germ cell tumor. Management: seminoma is extremely radiosensitive and has the best prognosis. Non-seminomatous germ cell tumor are not radiosensitive but respond to appropriate chemotherapy. And that is all. Wassalamu alaikum warahmatullahi wabarakatuh.